Here we have the structure of proinsulin that consists of two polypeptide chain A and B chain connected by C peptide or connecting peptide. The insulin consists of 51 amino acid arranged in these two polypeptide chains. The C peptide connect the two chains as well as give the proper position or alignment of the disulfide bonds that connect between the two chains, and it acts as indicator for endogenous insulin production. يعني احنا نقدر نقيس شقد عندنا سي بيبتايد، هاي معناها اكو عندي شقد انسولين، تعطيني تقدير شقد عندي انسولين دي يتكون، لانه بالبداية هاي البرو انسولين احنا عندنا السي بيبتايد بلس ذي تشينز ذي بوليبيبتايد تشينز، بعدين من يصير كليفج الانسولين يروح للستورج جرانيولز واحد ينخزن، والسي بيبتايد هم ينخزن بال بيتا سيل اوف ذا بانكرياس. فاحنا من نقيس السي بيبتايد هو indicator to the endogenous insulin production. البرو انسولين شافوا انه يشتغل كهايبوغلايسيميك agent also but to little extent. Insulin will be released according to an increased level of glucose or amino acid in the blood, usually after meal. So glucose will enter the beta cell of the islet of Langerhans by glucose transporter. It is subjected to phosphorylation by glucokinase, the glucose sensor. So this metabolism will increase the level of ATP in the cytoplasm and close the potassium channels. Depolarization will take place، ولذلك حيصير عندنا opening of the calcium channels and entering of high concentration of calcium to the cytoplasm. شنو الفائدة؟ حيسوينا contraction of the myosin filaments. المايوسين فيلامنتس اكو مسطره لستورج جرانيولز اللي تحتوي على الانسولين. So by this contraction these granules will be close to the cell membrane and will cause a pulsatile release of insulin by exocytosis. ايش راح يسوي لنا الانسولين؟ حيسوي لنا increase glucose and amino acid uptake, protein synthesis, increase glycogenesis, lipogenesis, promote cell growth، لأن هو anabolic hormone. إذا حيقل عندي الانسولين رح يصير الدايابيتس mellitus characterized by hyperglycemia, glucosuria, polyuria, thirst and polydipsia and polyphagia. If the condition untreated and we have a high level of glucose, we will get many complications. كل الباثيز الحصية retinopathy, neuropathy, nephropathy and also cardiovascular events. Many factors affect the release of insulin: glucose, mannose, ribose, amino acids, certain hormones like gastrin, cholecystokinin, incretin, while somatostatin, glucagon and adrenergic stimulation reduce and inhibit the insulin secretion. The half-life of insulin is about 3 to 5 minutes. We have biphasic release of insulin. We have the rapid initial secretion after the food intake, followed by secondary slowly release of insulin. Also insulin can be secreted by large amount when we have a tumor like insulinoma, so this will cause severe hypoglycemia. هالسلايد حيشوفنا البايفيزيك ريليز اوف انسولين. The blue color حيشوفنا sudden initial release of insulin after meal. لما عندنا فد كربوهيدرات meal فد protein راح يسوي لنا stimulation to sudden release of insulin followed by slowly release اللي هو second phase. الريد لاين هذا هنا عندنا impatient with diabetes اللي عندهم lack in the initial sudden release of insulin ولذلك ما عندنا proper metabolism to glucose وحيسوي لنا hyperglycemia وإنما كل اللي عندهم هو slowly decaying release يعني second phase. هذا بالتايب 2 diabetes mellitus. In type 1 اللي هي complete absolute destruction of the beta cell of the pancreas هذا البلاك لاين اللي ما عندنا نهائيا أي ريليز للإنسولين. When insulin released, it will act on its special receptors on different tissues, different cells, but mainly the liver, the muscle, the adipose tissue to produce many biological effect. The glucose uptake مثل ما قلنا, the amino acid uptake, protein, DNA, RNA synthesis, the glycogenesis, lipogenesis, promote cell growth, قلنا هو anabolic hormone فهذه كلها يسويها. زين اشتغل وقلنا الهاف لايف 3 to 5 minutes. وين هسه لازم يصير بي degradation 60% in the liver by tyrosine kinase and insulinase and 40% in the kidney by proteolytic enzyme. عندنا state of insulin resistance. زين ما رح يشتغل الانسولين. أما في حالة الobesity and in the presence of a tumor like insulinoma هالحالة رح يصير بيها down regulation of insulin receptor وكأنما عندي كمية أو عدد أقل من الريسبتورز. زين فما رح ينطيني البروبر effect. we have a state of insulin resistance أو insulin resistance can occur due to the presence of autoantibodies against the receptors or due to certain hormonal and metabolic disorder as in case of Cushing syndrome, acromegaly and gestational diabetes. Also many psychological and physiological factors can cause insulin resistance and the presence of diabetes mellitus. Is anabolic hormone, maintain the glucose metabolism, glucose homeostasis, and it has different biological activities. رح نبدي إنه الانترنس of glucose to the cell by insulin depend on the presence of glucose transporter. Glucose transporter type 4 will enhance the transport of glucose through the cell membrane of the muscle and adipose tissue. And also glucose transporter type 2 enhance the transport of glucose to the beta cell in the pancreas. So any deficiency in the glucose transporter type 2 will lead to the formation of or development of diabetes mellitus. In the liver تعرفون كل زين انه insulin enhance the formation of glycogen by glycogeno and inhibit glycogenolysis and increase glycogenesis. In the muscle by enhancement on the uptake of amino acid to inside the muscle, it will enhance the formation of or synthesis of protein, also stimulate glycogen synthesis. In the adipose tissue, inhibit lipolysis and increase lipogenesis, so reduce the formation of free fatty acid and ketone bodies. In diabetes mellitus, we have abnormalities in carbohydrate, protein, and lipid metabolism. So it is a heterogeneous group of disorder. Manifestation of this disease, usually we have hyperglycemia, When the level of glucose increase the renal threshold, glucose will appear in urine. So we have glucoseuria. Also hyperlipidemia, negative nitrogen balance and presence of ketone body, ketonemia. Increased thirst, polyphagia, polyuria, polydipsia. هذه كلها تكون موجودة عند patient with diabetes mellitus. We have different type of diabetes. First, we have the juvenile onset diabetes mellitus, or type 1, or it is called insulin dependent diabetes mellitus. إذا نجي على العمر, usually occur in childhood and puberty. إذا نجي على الكوز, إذا تريدون تسوون مقارنة بين الأنواع, ناخذ الكوز absolute deficiency of insulin. ليش؟ لأن عندنا massive destruction of the beta cell due to autoantibody against the beta cell, and also this can be triggered by viral infection and toxic chemicals. Glucagon level increased, non-obese patient, presence of ketone bodies. طبعا التريتمنت بما أنه complete destruction and absolute deficiency of insulin, لازم ننطي exogenous insulin. لازم نسوي insulin administration ونحدد الدوز according to the severity of the condition. مثل ما عرفتوا بالنسبة للإنسولين secretion النورمال subject. نجي على النورمال subject شو اللي حيكون عنده الانسولين secretion. اول شيء عندنا basal secretion اللي هو low level of insulin secreted by the intact beta cell in the pancreas. هذه دائما يكون عندنا low level of insulin to suppress lipolysis, proteolysis and glycogenolysis. زين, after intake of food ايش راح يصير within the first 2 minutes, خصوصا اذا اكو amino acid and carbohydrate, ايش راح يصير؟ عندنا الانيشيال rapid secretion of insulin اللي هو phase 1 burst of insulin secretion. هذا يبقى شقد 15 minutes followed by the second phase اللي هو منه slowly released insulin. زين, إذا عندي biphasic release of insulin after food. عندي البيزل ليفل هاي الاعتيادي low insulin secretion, وبعدين after food عندي phase 1 وعندي اللي هو rapid initial release, وphase 2 اللي هو slowly decaying release of insulin. In type 1 diabetes mellitus لا عندي البيزل secretion ولا عندي secretion of insulin in response to certain stimuli اللي هو الفود اللي هو جلوكوز وامينو اسيد, اثنينهم ماكو, وشفتوا البلاك لاين بالدايجرام قبل سلايدين. هنا قلنا ايش لازم ننطي؟ insulin therapy to avoid what? Different complication like the neuropathy, nephropathy, retinopathy. هذه شلون نعتمد على السيفيريتي؟ على يا تحاليل نعتمد حتى نشوف السيفيريتي of the condition. نعتمد على الفاستنج جلوكوز or random glucose level, fasting or random glucose level, وعلى الهيموغلوبين A1C glycosylated hemoglobin. هالهيموغلوبين A1C شنو الفائدة من عنده؟ ينطيني شقد كان عندي glycemic control in the previous 3 months, ويشوفني التريتمنت اللي أنا منطيتني good glycemic control, normalize the blood glucose level in the previous 3 months لو لا. على هالأساس نقدر نغير جرعات العلاج. In type 2 diabetes mellitus, or it is called non-insulin dependent type, usually occur in patients over 35 years of age, And we have multifactorial causes like the genetic factor, the aging, the obesity, the insulin resistance. We have no ketone body formation, and the patient can develop severe vascular complication. If it is associated with infection, can cause gangrene and lead to amputation of the limbs. We have insufficient release of insulin, which is cannot maintain normal glucose homeostasis. And in this condition we have insulin resistance, which is the major cause of this type of diabetes. Usually we advise the patient to take oral hypoglycemic agent and or insulin with diet, exercise and weight reduction to maintain normal glycemic control and to avoid the long-term complication. The third type is the maturity onset diabetes of the young. Usually occur in young patient before 25 years of age, autosomal dominant. We have no ketone body, also non-obese patient, and we have no insulin resistance. Sometimes diabetes can take place due to treatment by certain drugs like beta blocker, diuretics, steroid pills, and so on. The gestational diabetes, we have a glucose intolerance, which will lead to macrosomia, big baby, and also can cause shoulder dystocia that lead to difficult delivery, and also neonatal hypoglycemia. We can treat it by insulin, diet, exercise, but they found that metformin and glyburide is effective during pregnancy to reduce the hyperglycemia. The animal source of insulin, the bovine and the porcine insulin, can cause allergic reaction. So we use the human insulin, which is produced by the recombinant DNA technology using certain species of E. coli and yeast. By changing or alteration of the sequence of the amino acid, we can of human insulin, we can get different type of insulin with different pharmacokinetic properties. For example, we have the lysopro, aspart and the glulazine with rapid onset and shorter duration of action than the regular insulin. They form no aggregate or complex, but the glargine and ditimer have longer duration of action. Glargine form a precipitate at the site of injection, so the duration of action will be elongated, and they are less immunogenic than the bovine insulin. And we say that we have the commercial insulin properties differ from each other by altering the sequence of the amino acid in the human insulin, so they differ in the purity, in the concentration, solubility, the onset and the duration of action. What's about the types of insulin? We have the rapid, the short, the intermediate and the long-acting insulin, according to the addition of zinc or protamine or both to the regular short-acting insulin to change the duration of action and the onset. First, we have the rapid onset and ultra short-acting insulin preparation. First, we have the regular insulin. It is short-acting, soluble, crystallizing insulin, and rapidly lower the blood pressure, can be used in emergency and also safe in pregnancy, given subcutaneously or intravenously. By modification or alteration of the amino acid sequence that is present in the regular insulin, so new insulin analogs will be developed, like the lisopro, aspart, and glulisine. They have shorter duration of action and more rapid onset of action than regular insulin. For example, insulin lisopro. The amino acid lysine and proline present at position 28 and 29 on beta chain. These positions are reversed, so they got lisopro, insulin lisopro, instead of the regular insulin, with ultra short action and more rapid onset. These type, the lisopro, the aspart, the glulisine, will give more flexible treatment of diabetes with less hypoglycemic adverse effect. They are given 15 minutes before the meal or immediately after a meal. Again, shorter duration of action, more rapid onset, rapidly absorbed after injection, after subcutaneous injection. The peak level of lisopro within 30 to 90 minutes, if you compare it with that of regular insulin with 50 to 120 minutes. Aspart and glulisine have similar action, similar pharmacokinetic and pharmacodynamic parameter to lisopro. The short acting احنا قلنا رح تنطي rapid effect, rapid onset of action with short duration, lesser than that of the regular insulin. ولذلك ننطيها to get immediate hypoglycemic effect in combination with the long acting insulin preparation. فهذا ينطي immediate effect والlong acting تنطي maintenance, given by subcutaneous and intravenous injection during emergency, of course. Insulin lisopro can be used in external insulin pumps because they it will not form hexamers, and also the regular insulin, the lisopro and aspart are safe in pregnancy. So we have the inhaled insulin regarded as a short-acting type or analog of insulin, and the dry powder will be inhaled to be absorbed from the lung tissue to get a hypoglycemic effect within 45 to 60 minutes. The intermediate acting insulin preparation, like the neutral protamine hagidorn, also called isofen, it is a regular insulin plus protamine and zinc to form less soluble and give an intermediate duration of action, given subcutaneously but never intravenously because it is a suspension, and it is useful in type 1 and type 2 diabetes mellitus. Except in ketoacidosis, we need a regular insulin as emergency treatment. Also, we have a neutral protamine lisopro by using the lisopro type of insulin. The prolonged acting insulin preparation, we have the ultra-lenti insulin, large particles, poorly absorbed, combined the insulin with zinc crystal as a suspension, give slow onset, poorly absorbed, so give a slow onset and long duration of action. Insulin glargine forming a precipitate at the site of action and will site of injection and will liberate gradually, so it has a longer duration of action. It has a flat, prolonged hypoglycemic effect given subcutaneously. insulin detemir has a fatty acid side chain. يعني هذه الكاركترستيك اللي عندها هي اللي تخلي عندها longer duration of action. من عندها fatty acid side chain, it will associated with tissue albumin, then, and slowly dissociated from that albumin, so also liberated gradually over a long time. If you mix these type of insulin with other insulin in the same syringe, يعني مثلا regular insulin with insulin detemir, we will get different or alteration in the pharmacodynamic and pharmacokinetic parameters. يعني drug interaction ممكن يصير. Insulin degludic, another long acting insulin, and it has the longest half-life between the other type of long-acting insulin preparation. Also, we have aerosol preparation, oral spray, and the pen injectors, the continuous subcutaneous insulin infusion device, which is programmed manually to pump and deliver insulin according to the level of glucose in the blood. What's about the adverse effect? The hypoglycemia, usually with the preparation that are long acting, and also the lipodystrophy, which is hypertrophy or atrophy of the subcutaneous fatty tissue at the site of injection. So we should advise the patient to change the site of injection from time to time. Allergic reaction, weight gain, and also if the patient has renal disorder, try to adjust the dose. Also, it can cause bronchospasm, so avoid it in patient with asthma or obstructive airway disease. Uses in type 1 and type 2 diabetes mellitus, during surgery, during infection, trauma, or any other complication of diabetes, in gestational diabetes, and also for the treatment of hyperkalemia. Also, we have different combination of insulins. For example, we have 70% of MPH, the intermediate acting insulin, and plus 30% of regular short acting insulin, or 50% of MPH plus 50% of regular insulin, or also another intermediate insulin, 75% of neutral protamine lysoproinsulin plus 25% of insulin lysopro. All these available in the market.